I'm Cesar Libanati, Head of Medical Affairs and Medical Strategy at UCB, and I'm delighted to welcome you to the third episode of our Fragility Fractures in Focus podcast. In this podcast series, we're speaking with leading experts from across the global bone community, as well as the real experts, the patients, for their thoughts, insights, and tips as we explore the very latest developments in bone health and osteoporosis management. Together, we can elevate the importance of secondary fracture prevention and create a world free of fragility fractures. The inspiration for our podcast, aimed at all doctors who encounter osteoporosis in their daily work, is the P4 model, a framework increasingly recognized as the cornerstone of proactive modern medicine. The 4 Ps are prevention, personalization, participation, and predictiveness. The extent of patients' participation in their own healthcare journey and what this participation looks like is an increasingly debated topic in osteoporosis, and for very good reasons. So in today's episode, Power to the Patient, we'll be exploring patient-centered care and the impact this can have on clinical outcomes in osteoporosis. As part of these discussions, we'll be taking a specific look at shared decision-making and how we can implement this in our everyday clinical practice. And to help me to do this, I'm delighted to welcome our guest, Dr. Zoe Paskins. She is a rheumatologist at Keele University. Zoe, welcome, and please introduce yourself.
Thank you for having me. So, as you said, I'm Zoe Paskins, and I'm a reader in rheumatology and an honorary consultant, and I work as a researcher here at Keele and also lead quite a large osteoporosis service at a hospital in Stoke-on-Trent in the UK, which is an area which is quite deprived, actually. So I've got both of those roles, clinical and academic.
That is wonderful, and you're the perfect person for this podcast. And by the way, I know of your work and the actual area of patient-centered care and involvement of the patients and the public is a key area of your research, and you've done quite a bit, which you actually just presented at a recent major meeting of the Royal Osteoporosis Society. So what exactly is patient-centered care, and what does it look like in the clinical setting?
So, patient-centered care, or you might call it even person-centered care, actually, which may be a little bit broader, just to recognise that it's not only patients but also carers that we might be thinking of here. So person-centered care is about focusing on the needs of that individual. That at the most simple level, that's what it is. And we can think about that at the level of the clinical encounter or consultation. So it's about ensuring that that's collaborative. And really, I guess, in terms of your 4P approach, it's both participatory in that person is really participating equally in the discussion, and also about personalised medicine as well. I mean, that is part of person-centred care. So it's an umbrella term that encompasses quite a lot of different elements. So as well as thinking at it at the consultation level, we can also think about it at a hospital level or a service level, and thinking about are services designed with people and their needs? Are they accessible, etc.? Are patients and their carers involved in decisions about service design and that sort of thing? So it's really quite an overarching concept around focusing on those needs of the individual.
Great. Now, our listeners will love to hear perhaps some examples of the patient or, as you said, person-centered care that you've implemented in your own practice. And maybe you can also tell us what has been the response from the patients, which I'm sure have noticed it.
Well, one element of person-centered care is shared decision-making. So that's involving patient and clinician working together to solve a problem, any problem, in their consultations. And I guess that's the area of person-centered care that I've focused on most within my research. So I came to this as, there are lots of problems with osteoporosis care And lots of osteoporosis is misrepresented in so many ways and poorly understood. And to me, shared decision-making with that person-centered focus was the solution to a lot of those problems. So with that in mind, we here at Keele designed a 5-year research program to develop and test a range of resources to help patients and clinicians talk together about what osteoporosis is and the treatment options. And that's called the IFRAC program. That's what I was talking about at the conference. And we're just in the middle of a randomized trial evaluating those resources at the moment. But I could speak a little bit more about the development of them, or how the patient involvement that we've had in developing them and the initial testing. Lots of things that I could talk about.
Oh, I'm sure you can fill many podcasts.
Yeah.
I will have an opportunity today, I'm sure, to cover some of those aspects. But listening to you and imagining this in the clinical setting, it is obvious that you need time, correct? You need the time to talk to the patient, to educate the patient, to let them reflect on that, and then come to this bilateral agreement on what the best care would be for that person. How do you manage that? How have you had or not to adapt your clinic? Because everybody talks about patient or person-centered care, but to me it looks like time. The time is a valuable resource, particularly when you have a busy clinic. How have you adapted that?
So there's lots of research actually that shows that shared decision making doesn't take any longer than normal care. And actually, in the long run, it's more efficient, because if you and the patient, you as a clinician or practitioner, and the patient are on the same page from the beginning, then that's going to have efficiencies in the long term. So it's not just about education. I'm a bit wary about the term patient education, actually, because it's very variably defined. The important thing about shared decision making, probably the most important thing, is not just about giving information, but actually asking questions to understand the patient's beliefs and values, and then tailoring your response accordingly. And actually, we don't do that in consultations at the moment. So lots of clinicians, when we interview them, say, oh yeah, I already do. I'm very person-centered. I already do shared decision-making. But in our research, when we've looked at clinical consultations and what actually happens, less than 10% have got these sort of, the clinicians actually asking questions that engender shared decision-making. Another problem is that clinicians often think that shared decision-making is simply giving a patient a range of options and helping them choose, and it's much more than that. It's about helping them come to a decision that's in line with their values and their beliefs and their preferences. And if you don't ask the right questions, you won't know what those are. So if I give you an example, maybe it's easier to understand. So in a typical fracture liaison service consultation, maybe the patient's had, I don't know, a wrist fracture, and they've got osteoporosis on their bone density scan, and they come to a clinic and see a fracture liaison service nurse who does a model consultation and explains all about osteoporosis, and that they need to take a medicine to strengthen their bones. And they give the patient the medicine. They say, have you got any questions? And the patient says no, and the patient goes home. And then that patient thinks, well, that nurse told me I had osteoporosis, but they also told me that my osteoporosis was normal for my age. So why should I take a tablet for that? I'm not going to bother taking a tablet for that. But that never came out in the consultation because the healthcare provider was so focused on giving information, even giving education, you might say, that they didn't leave any space for that kind of belief to emerge. And this frequently happens. So when we look at qualitative research with patients and the reasons why they don't start or continue their medicine, it's often underpinned by these sort of beliefs that we might describe as misinformation or misrepresentation. So that osteoporosis is just a normal part of aging, or osteoporosis is why my joints hurt, and the medicine didn't make me feel better, so now I'm going to stop it, or things like this. So it's about giving space in the consultation for that to arise. And you can see that if you do that, it's more likely you and the patient are on the same page, and more likely that patient's going to commit to whatever they decide to do which is more efficient in the long run.
Well, this is very enlightening, and I think you already provided all of us with a great insight, which is it's about listening to the patients and allow them an opportunity to express. So I can imagine, for example, instead of telling them about osteoporosis, an open question like, you've been given a test result that shows osteoporosis. What do you know? What would you like to know about osteoporosis? And then that may allow them to basically express the areas where they have doubts, they have concerns, or they need focused information. Is that kind of the approach you take?
Absolutely, yeah. And it's helpful to kind of maybe tailor that. I do this all the time without thinking about it, but sometimes I say, "What do you know about osteoporosis?" But that can feel a bit like you're testing the patient. So I try and say something like, "What are your thoughts about it? Is it something that you've come across before?" Or without asking them, what do they know? Because that can, but I try to do that, but sometimes it slips out.
All right, another great insights, and we have two already. So start taking notes, I guess. I think this is relevant because in an area of osteoporosis also, and you've already kind of touched upon it a little bit. One of the big issues is that patients may start a medication, maybe recommending a medication, but wow, they stop it now. Actually, in some research, it shows that between 30 and 40% of the prescription for osteoporotic medications are never even filled, the first one. And it is not uncommon that physicians are not even aware or never become aware of that, which is a major issue. So, in your experience, and is there evidence that this approach is really, really having an impact on what is a major problem, that of the persistence of the patients taking the treatment over time?
Absolutely, yeah. And we have the evidence, not from osteoporosis yet, but from other disease areas, that shared decision making can improve adherence or concordance, if you might like to call it that. The other thing that has been proven to improve concordance to treatment plans is taking into account health literacy. So that's the ability of the patient to be able to understand and make sense of that information to make plans for their own, health behaviors or whatever. So health literacy is an important part of shared decision making. It's giving that information in simple ways that are easy to understand. So there is an evidence base that these kind of approaches can improve adherence. I think the approach that we've taken, and something I like about my work, because I'm a health services researcher, so that means that I'm involved in social science disciplines like sociology and psychology. So our work's all underpinned by psychological theories and theories of behavior change. And there's a particular theory around medicine's adherence called the perceptions and practicalities approach. And it's a really, really simple theory, but it basically outlines that there are three groups of reasons why people decide to either take or not take a medicine. And those three groups are whether you perceive that the medicine is needed or necessary for you, whether you perceive the medicine as safe or what concerns you've got, and then thirdly, the practical issues and can you actually do what's being asked of you? So attend the hospital for the relevant appointments or take the medicine in whatever way is recommended. Does that fit with you and your lifestyle and things? So it's really helpful, I think, in thinking about why people don't take their medicines to use that kind of framework of three things. And there's lots of qualitative research in osteoporosis, which gives great examples of beliefs or issues in those three areas that get in the way of medicine taking.
Wow, that's very exciting. Actually, I like everything I hear, and I assume also that in your current research, you're already exploring the outcomes to show that all the work you do and all the proposals you're moving forward indeed will have an impact. So a simple yes, I guess, will validate that.
Yeah, so we're doing a big trial at the moment looking at the impact of our decision tool and our other resources. And our primary outcome is actually it's a more person-centered outcome. So we're looking at whether patients feel confident in their decision making. That's our primary outcome. But we are collecting data on medicines initiation and adherence as well.
Well, that's very reassuring. Again, everything you say here makes absolutely perfect sense. Yet, as you probably have done, but as you review the consultations, etc., we find out that nobody or almost nobody does this or approaches medical care this way. Yet everybody talks about patient or person-centered care. There must be some barriers that are preventing this from happening. Can you comment on that? What those are?
Yeah, absolutely. I think we've mentioned two important ones already. So one is time and that perception that it takes longer. And as I said before, there's research that shows using a decision tool in the consultation doesn't take longer than a normal consult, for example. Another one is this perception that, well, I'm doing it already, and actually clinicians or practitioners not perhaps being aware of some of the skills involved. So that's why, as part of our suite of resources, we've developed some enhanced clinician training for those enhanced shared decision-making skills. Another barrier is that clinicians might assume that the patient doesn't want to make a shared decision. So, and this is true. If you ask patients, are you the sort of person who would like to be guided, or are you the sort of person who likes to know all the details and be able to weigh up the pros and cons and make your own choice? You know, a lot of people will say, I'd rather be guided by you as the practitioner. And that doesn't mean you don't do shared decision making then, because you can still understand what's important to that patient. Some patients find it quite intimidating, the idea of making a decision. But again, let me give you another example. So if, for example, you're talking to, let's say, I don't know, 75-year-old woman, this would happen in my practice quite a lot in the area that I work, because, as I said, it's quite a deprived area. And patients will often say, oh, you know best, doctor, I want to understand, what you think. So let's say I'm seeing a 75-year-old woman, and I say that question I've just asked, are you the sort of person that likes to make decisions and know all the information to make a decision, or would you prefer to be guided? And that person says, oh, I'd much prefer you to guide me. And I say, okay, well, we've got some options to talk about here. And it's still helpful for me to ask you how you feel about these so that we can make the right choice for you. And then in the process of talking about some options, let's say a tablet versus an injection option, I find out that this patient's got a terrible needle phobia. So she doesn't want to apparently engage in shared decision making, but actually by asking her questions about how she feels about the various options, I can understand what her values and preferences are. So her preference might be that she doesn't want an injectable treatment because she's got a real bad needle phobia. But if I don't take the time to find that out, I could just give her information about an injectable treatment option because she's asked to be guided, and she might not even have the confidence to disagree with me or say, oh no, I don't want that. And so you can use exactly the same approaches, whether the person wants to make a shared decision or not, to kind of find out what their preferences and values are and help them make a decision that's in line with those, if that makes sense. Yeah.
No, it makes perfect sense. And as you explain all this, I get the sense that it is not just about listening and having an opportunity for the person to provide her input or his input. There must be more than that. Are there any particular tools that you use or that can facilitate this approach?
Yeah, so there's a number of different decision aids or decision tools for osteoporosis. So a decision aid is a tool that helps patients weigh up the pros and cons of treatment or treatment options, perhaps compare treatment options. And usually a decision aid includes something which helps them think about what matters to them as well to help them make a decision. And we did a piece of research at Keele in partnership with the Mayo Clinic, actually, looking at existing decision aids and the quality of those and the effect of them. And we also got a group of patient partners to look at the decision aids and tell us what they thought of them. And the bottom line from that research was that our patient partners didn't fully like any of the existing decision aids and didn't find that any of them completely met their needs. And we also tested the quality of the decision aids against some international decision aid standards, and none of them met all the standards either. The one they preferred most was a Mayo Clinic tool, which is freely available online. But another thing that we noticed when we did that was that the decision aids vary into whether they're individualized or not. Some of them are just standard documents that you can print out, and they're the same for everybody. And our patient partners didn't like those at all. They were too vague, and they much preferred the tools that were individualized. So for example, you could put your own fracture risk in to see, risks and benefits for you as an individual. So we took the information from that exercise as a starting point to develop our own decision tool at Keele, and that's the IFRAP tool that we're testing at the moment. And it is different from anything that's available at the moment because it integrates a lot more of shared decision-making practices into it. So there is a training package that goes alongside it. And the tool is interrupted by screens which force the clinician to ask the patient questions. So it doesn't turn into an exercise of the clinician just reading out all the information in the tool. It's web-based, it's individualized, and it's got animations in explaining what happens inside the bone. And we're hoping that's going to be available next year after the trial's finished.
We're looking forward to see it in vivo. Is this also related to the IFRAC, or the IFRAC is a different, you had mentioned earlier today, that's another area that you've done quite a bit of work and research?
Yes, it's the IFRAP study and the IFRAP tool and the IFRAP training package. Yeah, they're all part of the same thing.
All right. Maybe you can tell us at a very high level, what does that do, and what input does it require from the patient? When would the patient would do that? Before the consultation, during the consultation, after? How is that being implemented, or what is the vision?
Yeah, absolutely. So it's designed to be given in a consultation in a fracture liaison service. So maybe at that point of initial diagnosis of osteoporosis. And it's designed to be given by the clinician and patient talking together. So there's a clinician part, first of all, where the clinician enters very few brief details about the patient, like their fracture risk, age, and gender, and their bone density results if they're available. And then that populates some information in the patient-facing part. And then the clinician can turn the computer screen towards the patient. And there's 4 sections that they work through. One is why bone health matters and why it's important. And there's an animation there of what happens inside your bone as you get older, and some explanation about why fragility fractures are important and the biopsychosocial consequences of those. The next section is about the patient's own risk factors and results, so they can understand why it is they might have come to have osteoporosis, what their bone density is and what their fracture risk is, and there's some different visual ways of presenting that information. The next section is a positive message and ways to improve bone health, to emphasize that osteoporosis is a treatable condition, and and the patient can choose which elements of they would like to discuss, and there's options around diet, exercise, lifestyle behaviors like smoking and alcohol. There's also a section on thoughts and feelings, which our patient contributors said was important that we should include. And then in the middle of that, a section about medicines. So the discussion is around the lifestyle bits directed by the patient, and then it ends with a discussion about medicines. And the medicine section is very simple information around why medicine is important, what the side effects are, with a positive message about how side effect risk can be reduced, and then the practical issues. So covering those 3 areas that I mentioned earlier. At the end of the tour, the last section is filled in by the clinician and patient together, and the patient has a chance to say how they feel about what they've been told, what they are concerned about, whether and what matters to them in terms of medicine benefits and side effects, and whether they're willing to take it or still unsure, and then a little bit of information about next steps. And that all feeds into a printout PDF, which is called My Bone Health Record, and it's got brief information from the first 3 sections, the patient's answers to those questions at the end, and then one side of A4, which is a very, very simple drug information with those 3 categories, why it's important, what the side effects are, and the practical issues of the chosen medicine. And that goes to the patient afterwards for them to discuss with their friends and family, and their primary care provider as well.
Very clear. As you're telling us all this, I'm reflecting, and we just came from a large meeting where there were meet the expert sessions, and we've been to meetings where you have workshops. I may have missed it, but I don't remember seeing a person-centered workshop in terms of an approach will be kind of a role playing, because it looks to me like seeing you doing this, for example, will be very enlightening and would help all of us to indeed approach the way we discuss treatments and options for the patients in a very different manner. Is this something that you've also have thought about, or maybe since you are in the community to set the programs for many meetings, maybe we'll see that in the future?
Yeah, I think we are definitely seeing it more at conferences. And actually, there was a session at the Royal Osteoporosis Society, and it was called Speaking My Language. And there was a session with some patient testimonies about how important their consultations with health professionals have been. And Professor Joe Prothero from Keele was giving a talk on health literacy, and then I spoke about how we can address some of these health beliefs and misrepresentations about osteoporosis in consultations. And certainly at osteoporosis conferences in the past, I've also spoken about some of these shared decision-making techniques and things. So I think we're seeing it more and more at conferences, and people are beginning to recognise the importance of these kind of skills in addressing the problems that we face in osteoporosis with the poor uptake of treatment.
You are right. I now remember in the program that session. So another question I think our listeners may have is there kind of some work that the patients could do ahead of their consultations, or you find out that do they come already with already too much self-acquired, I guess too much is a poor description, but maybe more than we like, self-acquired knowledge from having read Dr. Google? Do they, I know there's plenty of resources, correct? I mean, the Royal Osteoporosis Society has wonderful resources. In your experience, are they being used sufficiently? Is there something that is important? And if it is, how can we incite the patients indeed to get even more proactive, or direct their proactivism in a way that will be beneficial?
Yeah, that's a great question. And I think you've touched on a really important area there about how prepared people are for their consultations. I heard somebody at a health literacy conference give a fantastic example of this, that if we went to see our bank manager and we didn't know what was in our bank statement, and the bank manager told us that we were really heavily overdrawn, we would then start to feel quite anxious, maybe a bit sweaty and a bit panicky, and maybe then that would make it harder for us to think about the questions that we need to ask of our bank manager, because we're a bit on the hoof and we're not prepared. And it's exactly the same in consultations, where if a patient comes and maybe they receive a new diagnosis that they're not expecting, then they can't get the best out of that consultation because they're perhaps feeling anxious, trying to take it all in, and can't think of the right questions to ask. So being prepared for consultations is really important. And if I'd had my time again, I probably wouldn't have designed the IFRAP tool such that it needed to be solely guided by a health professional. And one of the next things we urgently want to do is to make some adaptations to it so that patients can look at it in advance, and it can help them with their just help them be prepared so they can think of the right questions to ask. There's other ways as well that we can help patients to be prepared. And for example, we did some research in fracture liaison services where services have one-stop appointments where they perhaps do an assessment, a bone density scan, and give patient a diagnosis and treatment recommendations all on the same day. And while that's brilliant and really efficient, we found that patients were really unprepared for that, and certainly unprepared for a diagnosis. And so by sending out information that's easy to understand before the appointment, but telling the patient what to expect, that's a very simple thing that's helpful as well.
Are you aware of any efforts, and maybe that's another idea for potential research and activation of uses of AI? I can imagine, for example, typing in ChatGPT. I'm 76. I just had a vertebral fracture. I live by myself. And my T-score, I was told, was minus 2.6 or minus 2.8. What should I ask my doctor? Actually, I'm gonna try that later on to see what ChatGPT suggests we ask the doctor. I'll let you comment on this crazy idea, maybe.
I don't think it's crazy, and that's the way the world is going. But we have to be really cautious about AI because it's at the moment, because of course it's fed by information in the web. So at the moment, if you ask, for example, a AI tool which creates images to create an image of somebody with osteoporosis, they're heavily influenced by stereotypes of aging and stereotypes around osteoporosis. And I think that is the same of text tools as well, in that you might be getting some input from some of the misrepresentations about osteoporosis that we know is on the web. So I think thinking about how we use AI in its broader sense is absolutely a really important question. But I'm a little bit cautious of it at the moment because it's only as good as the information which feeds it. I think in terms of preparing people, there are some very simple campaigns, and there's one in UK called It's Okay to Ask, and there's another one called Just 3 Questions, where they are more generic ways of helping patients to prepare for their consultations and just think of the simple questions that they should ask, which are probably relevant in all cases. Like, for example, what are my options? What will happen if I don't do this thing that you're suggesting that you want me to do? There are simple tools available already we can point people to help them prepare.
An area obviously to watch. You mentioned earlier in the podcast that in other areas and diseases, maybe person-centered outcomes, person-centered care has already taken a more forward leap, and they have results and outcomes, etc. Are there things we can learn from those experiences in other diseases, things that we should try to accelerate, pitfalls that we should try to avoid?
Yeah, that's a really good question as well. Yeah, I think person-centered care is probably more advanced in some areas of medicine than others. It's definitely more advanced in primary than secondary care in general, I would say, well, certainly in the UK. And I think that's because the consultation is the currency of primary care. So there's a lot more emphasis on training and consultation skills in primary care. In terms of what we can learn from it, that's a really good question. I'm going to have to reflect on that. But I think we have, as I said, more of an evidence base in other conditions. I probably mentioned a bit of that already about how these sorts of tools and techniques can help not only with patients feeling like they're more involved and like it's more of a person-centered consultation, but also helping with the more clinically important outcomes, if you like, around commitments to medicine.
It's been already almost a long time since we've been talking, and I mean the time is flying, which is wonderful, and it tells us how interesting and how important this topic is. I'm gonna try to close here with a final question for you. Obviously, you're very excited about that. Obviously, you're a pioneer and example about this approach. Are you excited about how we are all following your example? Do you have a kind of a call to action to everybody? How do you see the future unveiling in terms of this very important area if we want to improve outcomes in our patients?
Thank you. Yeah, I am really excited, and I do see a bit of a paradigm shift happening, and I hope so. I think for maybe the last 10 years, academics and experts in osteoporosis have been writing about the osteoporosis crisis and poor treatment uptake. And there's been a lot of blame placed at the foot of the media, for example, for highlighting negative reports about medicines. But I think as clinicians, we are all missing a trick massively in just how we explain osteoporosis in a way that people can understand. It's not a well understood condition. It's really misrepresented. And so my call to action is to clinicians to realize that and just understand the importance of giving and explaining a diagnosis. And asking patients questions about what they already know and believe and think. And I think if we all did that, then we would see really quite different outcomes.
Well, I can only thank you so much for the time. Thank you so much for all the work you're doing and for your insights and for being an advocate at the end of the day for better outcomes and for the person, for the patient. So. Again, myself and on behalf of UCB and of all the listeners of the podcast, really thank you. I'm gonna summarize a little bit my key points from this podcast, from what I learned listening to you and regarding person-centered approaches to care. Obviously, it is a much-needed approach if we want to attempt. Actually, we've already shown success. Important improvement in outcomes for patients in their osteoporosis treatment journey, something that is so dearly needed. The approach is simpler than what we may think, and it starts with listening to the patient, give them an opportunity, open questions, etc., as opposed to try to educate the question in the traditional manner. That's obviously not the way we have been trained, so we need to learn. We need to be humble and learn from those who are doing it well. And that will allow us to reach that opportunity to obtain and to reach that shared decision, which, as you very firmly believe, is key to having an important improvement in those outcomes. So from hearing to you, I think the future is exciting. It is actually here. These tools are imminent that will help us. But it's not only the tools, correctly. It's the approach. Is us taking a conscious approach to not spend more time, as you said. This can be done in the same amount of time, and maybe, as you very well said, with some efficiencies. So I again want to thank you so much, Zoe, for your generosity in providing all these insights, all these tips, and I would like to remind the listeners of the call to action. It was very clear from Zoe. So let's go and do it, put it in practice while we take care of patients. And for all of you to look at for UCB at the upcoming Fracture Fragility Network Congress, another opportunity to indeed start seeing these important actions in place. So thank you again.
Thank you very much for having me. It's been my pleasure.
And on that, I wish you all a great rest of the day.